Welcome to the Oregon Poison Center's 2026 National Poison Prevention Week Healthcare Lecture, No Laughing Matter, Clinical Insights into Nitrous Oxide Misuse. My name is Jennifer Eskridge, and I'm the Community Outreach Educator at the Oregon Poison Center. This webinar is being recorded and will be posted to the Oregon Poison Center YouTube channel in the coming weeks. Questions for our speaker will be addressed at the end of the presentation as time allows. Please use the Q&A box to input your questions. Our speaker today is Dr. Courtney Temple. Dr. Temple is a medical toxicologist and emergency physician at Oregon Health and Science University and the Oregon Poison Center. She grew up in central Massachusetts and completed both medical school and emergency medicine residency at the University of Massachusetts. She then moved to the Pacific Northwest to pursue fellowship training in medical toxicology at OHSU and has since stayed on as faculty in both research and education roles, currently serving as the Director of Medical Toxicology Education and Assistant Medical Director of the Oregon Poison Center. Her academic and research interests include novel psychoactive substances, emerging drug trends and surveillance, and medical toxicology education. Next slide. Participants will receive a follow-up email that will include instructions on how to claim CME, including the required evaluation and CME payment. Both components must be completed to receive credit. CME credit is only available for the live presentation today. Join me in welcoming Dr. Temple.
Hi, everyone. Thank you so much for having me today. I'm so excited to be a part of National Poison Prevention Week 2026. And I'm thrilled to be talking about this particular topic because it's one of my academic areas of interest, and we are experiencing quite a large resurgence in clinical relevance for nitrous oxide misuse and toxicity. So I'm hoping to leave everyone with some practical insights applicable across multiple specialties. I have no disclosures. And today's objectives are going to be threefold. So first, we're going to examine the patterns of nitrous misuse and discuss key toxicologic mechanisms underlying its toxic effects. Second, we are going to review the varied clinical presentations and diagnostic approach, and we're going to pay special attention to neurologic and psychiatric complications. And then finally, we are going to discuss treatment strategies, recovery trajectories, and what I think is an under-discussed component of this, which is the evolving public health and policy landscape surrounding misuse and abuse. So let's start with a clinical case to sort of anchor our discussion today. I think it's important to provide an initial framework for the way that these patients present so we can talk about some of the nuanced aspects. But you already have a leg up. This isn't a mystery case. You know the toxicologic culprit, but there are some interesting surprises that are going to pop up. So we are going to imagine that this patient has presented to an emergency department. She is a 24-year-old woman with a chief complaint of bilateral leg weakness. It's been ongoing for several weeks, and she says that she has leg numbness, poor balance. She's fallen multiple times at home, which is unlike her. And we find ourselves focused mostly on her mobility because we notice she arrives to the ED in a wheelchair because of her functional limitations. So notably, she's already had multiple prior visits. She tells you she's been to the emergency department, she's been to urgent care, she's been to her primary care provider, and her basic labs, a CBC, a metabolic panel, thyroid studies, pregnancy tests, iron studies, vitamin B12, they're all normal. And she doesn't know what's going on. So she's coming to you for help. So we asked her for more history, but her past medical history is relatively unremarkable. She's has limited childhood asthma. She takes no medications. She denies tobacco use. Says she does use cannabis occasionally while she's living with her roommates, and she's pursuing an education degree. So there's no significant family history apart from some hypertension. So on initial review, nothing seems particularly high risk or out of the ordinary. So for this case, we're going to assume that her vital signs are normal and stable. And on her exam, she has some particularly pertinent findings. So she has symmetric lower extremity weakness. She has diminished sensation to both light touch and pinprick below the knees. And you even assess her vibratory response, which is absent at the toes and ankles. Her proprioception, so her sense of balance, is grossly impaired. Her reflexes, though, are fine. Her patellar reflexes are normal, but her gait is very wide-based. It's unsteady. It looks like she could fall over at any moment. And she demonstrates a positive Romberg sign. So when she closes her eyes and tries to stand still, she's losing her sense of balance and is almost falling over. But she doesn't have any fasciculations or muscle tremulations. She doesn't have muscular rigidity, and her upper extremity strength and sensation is normal. This is really isolated to the lower extremities. So we can start to characterize her as having a peripheral neuropathy, that decreased sensation, and paresthesias, that numbness, tingling in the feet, but also findings concerning to the posterior spinal column as being involved. So that's something we're going to return to when we talk about the pathophysiology of this, but it's often subtle. And the constellation of findings, that ataxia, that imbalance, that proprioceptive loss, and the vibration sense impairment, these are all clinical clues that with a good exam, we can start to isolate where the problem is. So we're going to add to her initial workup. We already said prior visits have been normal. They've found quote unquote nothing. So we've redrawn her chemistries. We've redrawn a complete blood count and a vitamin B level. And her initial lab results remain largely reassuring. Normal electrolytes, normal renal function. She does have a mild anemia, and her MCV, so that marker of how big her red blood cells are, you note is somewhat elevated at 108. But her vitamin B12 concentration is normal, well within normal range. Um, and a CT angiogram of her head and neck, so to look for strokes, to look for other intracranial abnormalities like intracranial bleeding, that's normal. Completely unrevealing. So we've ruled out acute vascular or other intracranial pathology. But at this point, a unifying diagnosis is still somewhat elusive. So we're going to take a step back. And at this junction, our differential diagnosis is really broad, right? So this list is admittedly very limited, but we might consider demyelinating diseases such as multiple sclerosis, infectious or autoimmune processes. We could consider nutritional deficiencies, copper, B12, vitamin E that result in a lot of balance issues, neuropathies caused by things like diabetes or excessive alcohol consumption, but we don't have any evidence of that either. And in terms of toxicologic differentials, I might start thinking about medication side effects, but she doesn't take any medications. She's not on chemotherapy. She doesn't have any exposures to heavy metals, solvents, or inhalants, we think. So we might want to go back to our patient and reconfirm some of this stuff. No exposures, trauma supplement use, right? Or other substances. But then she somewhat offhandedly mentions to you that she's been using whippets. And she says, I don't really think that this is a drug. It's just those whipped cream chargers, and you can buy them at any store. I use them a few times a week just to chill out, and it's food grade, so I figured it was safe. So now here's where we can focus our clinical concern. Nitrous oxide, commonly referred to as whippets, has reemerged as a drug of abuse, particularly among adolescents and young adults. And despite this perception as being benign, we now know that the physiologic consequences can be pretty profound. So let's do a little background. So nitrous is a colorless, odorless gas, and it's used medically. That's where we most often hear about it. It's an inhalational dissociative anesthetic for procedural sedation, in dentistry, in labor and delivery, and also commercially as a food propellant for whipped cream, foams, other culinary preparations. But it's also used in an industrial setting as an automotive performance and racing. Um, Substance to as a propellant. It propels cars forward. So in the racing industry, and it's also used in chemical manufacturing, some electronics industries. But really, where we're seeing this problem with public misuse is from the culinary aspect. So recreationally, young adults or other users are buying these over the counter. Or online, and it's inhaled from these whipped cream chargers or larger tanks like you see these kids holding right now. And it produces short-term euphoria, analgesia, dissociation, and these effects contribute to its popularity in social settings or by oneself. But like many other recreational inhalants, beyond the euphoric effect that the users are targeting, there are other biochemical side effects that lead to cumulative toxicity. I just like to take a little step back and look at the history because sometimes that's the most interesting part of a substance's sort of growth throughout history. But this has been around for a really long time. In the late 18th century, a British chemist experimented with the gas and coined the term laughing gas, which is what we still use today. And he did that after observing its euphoric effects. Um, he proposed that it could be used in surgery, but it wasn't until the mid 19th century that nitrous became a staple in medical and dental anesthesia. So this was before that. Recreational use emerged before its medical role, and it was being used at parties and as public entertainment. Then there was this notable cultural resurgence in the 60s and 70s where it became known as hippie crack. And that was usually used at music festivals. Balloons were passed around for its brief dissociative high. And then through the 1990s and early 2000s, it's very common to find at raves in club cultures. Um, but the whipped cream chargers or the whippets were easy to buy, became a low cost, fast acting high among partygoers. And then in the past decade, recreational use has escalated dramatically with the rise of these large volume industrial tanks. I'm going to show you a couple of examples. So to reiterate, this has been around as a party drug for a very long time. This is a wood carving of the exhilarating effects of nitrous from 1840. Okay, so in the modern era, nitrous misuse is resurging among young people, and whippets were readily available online or in community shops. Social media trends, flavored tanks, inaccurate perception of safety have all contributed to widespread use. And the normalization of this as just a party drug has outpaced public health messaging by quite a bit. So I want you to take a look at these two preparations of nitrous. The larger tank on the right has about 4.5 liters of nitrous in that, and it contains 3 kilograms of nitrous oxide, and it even comes with a carrying strap so that you can carry it around easily. The left preparation, these are the whippets. These are those small cartridges, and they contain about 8 grams of nitrous. So you would have to load a couple of those into a whipped cream charger, meaning those taller whipped cream um, canisters that are metal, and then add your heavy cream in. And then that is what aerates it into whipped cream, and you spray that out of the nozzle. You can imagine, though, these larger canisters you can either attach a tube, a hose, you can use a mask, and you can get a nozzle that you can inhale directly from also. So, as I said, these were extremely easy to find on Amazon or other online retailers like Walmart. There were dozens of cartridge packs or the larger tanks from the previous slide in stock available for immediate delivery. But actually, I noticed as I had been continuing my research throughout this topic that in the last couple of months, actually, I noticed that online, all of a sudden, we started to see that they weren't readily available anymore. Um, you can still get them, but there are only a few sellers, and most of the larger tanks, those companies, have begun making their own websites. And that requires age verification. You have to take a photo of yourself and put in your license number to have it shipped to you now. Before that, over the past several years, the sales had surged. Amazon listings were noting hundreds of purchases per month. Market research estimates had the US whipped cream charger market at about 500 million in 2024, which was significantly up from earlier in the decade, but medical use still outpaces that by quite a bit. But when I tried to research what had actually happened on these large retailer sites like Amazon, specifically for Amazon.com, as of November 5th, 2025, Amazon stated that they will no longer sell nitrous tanks or any 8 gram nitrous canisters with more than 10 units per pack. So on this slide, you can see you used to be able to buy a 600 pack of the Ultra Pure Whip. You can get that for about $200, and you could get it delivered right to your door, next day. But right now, they're a little bit more difficult to find. This is just another interesting piece of this entire story. So in prior years, There were these large distribution networks, and they were often dubbed the nitrous mafia in media and public health circles. And they are sort of these organized syndicates that uh, emerged in major urban centers across the US and abroad. But they operate semi-openly, pretty much openly, and they were delivering high volume tanks to parties and festivals. And then they would fill balloons and they would hand them out to partygoers, and you could see they could make quite a bit of money for this. But what's concerning now is the shift from the small scale whippet use with the balloons to the industrial sized tanks. Some of these hold the equivalent of hundreds of cartridges. And during some surveillance sweeps after these festivals in major cities, they found entire parking lots littered with used canisters. Okay, so we're going to talk about the mechanisms for a couple of minutes. We're going to go into the weeds for a second because it's really important to sort of get an understanding of how the nitrous actually affects the body and what's creating this toxicity. So again, nitrous exerts its effect through several mechanisms. Two of them are highly desired by users, and one is an inadvertent side effect. So the NMDA receptor antagonism is primarily responsible for its dissociative properties, like ketamine. But it also stimulates the endogenous opioid pathways, and that provides the transient analgesia and euphoria. But the most important part of the toxicity profile is this inadvertent side effect, which is that nitrous irreversibly oxidizes, essentially inactivates the cobalt ion in your vitamin B12. So in your entire molecule of vitamin B12, you have a cobalt center, and it changes the state of that center such that it cannot participate in any metabolic reactions. And this disruption of the cobalamin, that cobalt center biochemistry, is central to its toxicity. So this is a pathway that myself and Dr. Horowitz in the Poison Center had made for a prior paper of ours to try to describe how this pathway works. And essentially, you can see in the middle, the nitrous and the B12 interaction is highlighted. And again, it oxidizes the central component of the vitamin B12 into a biologically inactive state. And this creates a functional B12 deficiency. Um, that's going to disrupt the body's ability to support essential enzymatic reactions that B12 is a cofactor for. And it's a really important cofactor for both sides of these metabolic pathways. The result then is this cascade of biochemical failures, essentially, even in patients with adequate nutritional intake and no other risk factors, because we have inactivated it. We haven't removed it. It's there. It just is not able to participate in any of these reactions. So one of the most critical implications of this is the inhibition of the methionine synthase methylcobalamin complex. Um, when that happens, it cannot participate in downstream reactions, and this results in impaired methylation of proteins, including those that are essential to myelin maintenance. So that myelin structure that is what covers our nerves and is essential for nerve conduction. So when methylation is impaired, the structural integrity of our myelin deteriorates. And this contributes directly to direct demyelination, particularly of the posterior columns of the spinal cord, and it can also affect the lateral columns as well. So those two parts of the spinal cord are going to give us our issues with sensation, balance, and motor, so the weakness. Next down the line is this inhibition of the homocysteine pathway. So you can see the star right next to that. Because methionine synthase cannot participate in this, we end up with elevated homocysteine levels. And effectively, we have disruption in DNA synthesis in rapidly dividing cells, particularly within the bone marrow and the nervous system. So this is contributing to the megaloblastic anemia. This is a hallmark of vitamin B12 deficiency, but also it could be a hallmark of folate deficiency. We see that in the same processes. So we're going to talk about that. We're going to keep that in mind for a little bit later. But essentially, it's limiting the body's ability to repair and regenerate nervous tissue. If we go to the other side of this diagram, a second enzyme, methylmalonyl CoA mutase, is also B12 dependent. So now we also have impaired activity of adenosylcobalamin, which is our other active form of B12 in the body. This inhibition leads to an accumulation of methylmalonic acid, or MMA, and that is a neurotoxic metabolite. That's going to directly damage axons in both the central and the peripheral nervous systems. And that's why patients often present with these mixed motor and sensory findings. So the result of demyelination and axonal degeneration. So this is a big slide, but we're just summarizing. So we have impaired methylation and DNA synthesis, which is disrupting all of our myelin maintenance and repair. This is also going to lead to anemia and increased mean corpuscular volume, so the size of our blood cells, another clue. And byproduct accumulation is going to promote that axonal damage. So together, all of these processes are going to culminate in a diagnosis that we can describe as subacute combined degeneration of the spinal cord. So we're going to go back to our patient and sort of sort through her findings. Our patient's weakness reflects this physiology. She has peripheral neuropathy from the axonal injury. She has posterior column dysfunction consistent with the subacute combined degeneration resulting in weakness. And these findings are often bilateral and symmetric, insidious in onset though. So that's going to often delay recognition. Most patients are going to present and say that they just have tingling in their feet. Our patient came in at a very severe state, right? She couldn't walk. But most patients aren't even going to connect that their peripheral sensory issues are connected to their nitrous use. Okay, so the anemia component. Remember that her B12 was normal, but her MCV was elevated and she had a bit of anemia. This is due to that impaired DNA synthesis and disrupted heme metabolism. Um, to make things a bit tricky, the anemia and macrocytosis may not be present in 2/3 of cases. Um, so while its presence can be an early clue, we sort of need to have a high suspicion of this through our history taking and our physical exam. Now, there's another potential side effect of this, which is not really widely known, but it is certainly well documented in the literature. Nitrous abuse confers a thrombotic risk from that hyperhomocystinemia, so that elevated level in homocysteine after the methylcobalamin and methionine synthase cannot participate in that reaction. The elevated homocysteine levels are going to promote endothelial injury, platelet activation, and thrombosis. So there are case reports describing renal infarcts in heavy users, likely due to microvascular clotting that's driven by this methylation issue. But this is a case series of 326 recreational users, heavy users, that found that 5% of them developed serious thrombotic events. All of them had extremely high homocysteine levels with a median of 125 micromoles per liter, which is over 8 times the upper limit of normal. But these patients had used massive amounts of nitrous. You can see 6,000 grams per session, whereas a single whippet is 8 grams, which on the low end puts you at 50 inhaled cartridges. Um, so we're talking about a lot of nitrous. Unfortunately, at one of our sister poison centers, they actually had a very recent case of a very, very high volume nitrous user who unfortunately had a major fatal event with a large pulmonary embolism. And the only risk factor that that patient had, who was a young, otherwise healthy person, was his elevated nitrous use. There are some other side effects that, again, we don't really talk about very often. We might consider returning to our patient to ask about her mood, memory, and cognition. So the NMDA antagonism contributes to that dissociation, but the excitotoxicity and glutamatergic dysregulation can result in anxiety and other psychiatric findings. Secondarily, our impaired methylation that I keep talking about pops up again because it turns out that that's also essential for neurotransmitters. So it's going to alter your dopamine and serotonin synthesis and overall neuronal regulation. And this can cause apathy, depression, mood lability. And the psychiatric effects can persist even when those physical symptoms resolve. And there is literature to suggest that psychiatric complaints may be the only symptom in some cases. So unless you ask, you may not be able to put those pieces together. So this triad of neurologic, hematologic, psychiatric effects These are all characteristics of nitrous toxicity. And again, the neurologic symptoms are the paresthesias, the weakness, the imbalance. The macrocytic anemia is present in about 2/3, meaning in about 30%, you're not going to find it. And the psychiatric manifestations range from very subtle mood shifts to frank psychosis. So, how can we start tailoring a workup to this patient? We know that the serum vitamin B12 is often misleading because it can be normal. We have had many users tell us in our research at the Oregon Poison Center that they have gone online, they have gone on Reddit, other user forums, and gotten recommendations about how to prevent, or potentially prevent, I should say, these toxic side effects. And a lot of what the users are sharing with each other is, oh, you should take vitamin B12, and that will stave off the neurologic effects. And the truth is that that doesn't work so well because the more B12 you give, or the more supplementation you are bringing on board, if you're still using nitrous, you're still inactivating it. But what that can show, though, is you can have completely normal or elevated serum B12 because they're taking more in and it's there, but it's just not active. It's completely inactivated. More specific markers, though, are going to include an elevated methylmalonic acid and homocysteine. So we should be getting both of those labs, and that's going to reflect our disrupted intracellular metabolism. Um, Imaging of the cervical and thoracic spine via MRI is going to be critical to assess for that myelopathy. And I'm going to show you some specific findings on the next slide. But also EMG can further characterize the extent of peripheral nerve involvement, but that's not going to be done in an acute care setting. So that's going to be with our follow-up and long-term planning. Okay, so if we were going to do the best we could at confirmatory testing, we would get that homocysteine concentration, the MMA concentration, and then we would image the C and the T spine. The MRI is typically going to show a T2 hyperintensity of the dorsal columns, and it often comes with this classic inverted V sign, which you can see in figure A. And these findings are most prominent in the cervical spine and the thoracic cord, which explains the disproportionate lower extremity involvement because those are our longest pathways. So again, EMG and nerve conduction studies are going to often reveal a sensory motor axonal polyneuropathy, and that's going to correlate with our functional deficits like poor balance and lower extremity weakness. And these changes can persist again with early treatment. And that should really highlight the importance of early recognition. So a colleague of mine had reached out and said that she has seen countless patients now with this exact finding in her clinic. Um, and she had sent me some information about that tracks exactly along what you're seeing on this slide. So EMG, NCS, these might be important again for outpatient long-term follow-up and recovery strategies. In terms of a treatment approach, really, and I put this at the bottom with a star, but really it should be at the top because it hinges on cessation of nitrous. Um, we are going to tell the users to stop, right? Because as long as they are using nitrous, they are inactivating their B12. And even if we give them B12, they're going to still continue that process and be susceptible to toxicity. But the treatment foundation is really going to be high dose B12. Usually, we're going to start with 1 milligram IM daily for 2 weeks, and then we're going to start to space it out. Although there is now literature that suggests that oral supplementation is just as effective as parenteral therapy, which is great because you can imagine to have a patient keep coming back to clinic or the ER or primary care for B12 injections, daily for 2 weeks and then weekly, we are going to be at risk for loss of follow-up and inadequate treatment. So we'll put oral also on this foundational treatment strategy. And then physical therapy, neurology, maybe tox follow-up are going to be essential to support functional recovery. And then again, I'm going to mention this several times because we are in a functional deficit here. So circulating B12 may appear adequate, just not biologically active. And without cessation of nitrous use, supplementation alone is going to be insufficient to restore that normal enzymatic activity and or help with the neurological damage, help to reverse whatever we can. We might ask an astute question based on that diagram I showed you. Why don't we just supplement with methionine to bypass that methionine synthase inhibition, or maybe folate, right? Um, but actually, there's really almost no evidence in the literature right now that confirms either of these are going to improve neurologic recovery in nitrous-induced myelopathy, but they are low risk and generally inexpensive. So at the Poison Center, we are going to recommend that we do give these to patients as adjuncts in the overall treatment approach. We just have to remember that until that enzyme recovers, we have to synthesize a new enzyme in order for any B12 or methionine or extra folate to work. And that can take anywhere from several days to several weeks, depending on what kind of volume you're using. But essentially, B12 is going to remain the cornerstone of our management. This is a publication that our Poison Center put out in December of 2025 about the trends that have been ongoing over the past 22 years reported to the National Database of Poison Systems. So this is all across the country. And what we essentially found was that there's been this dramatic increase in reported nitrous oxide exposures. So it began as maybe isolated cases, right, from 2003 all the way up to about 2019, now has this consistent upward trend. Um, you'll notice that the substantial increase really started in 2020 during the pandemic, and it's only continued to rise. Demographically, the largest proportion of cases are occurring in young adults, especially those aged 20 to 29, which actually tracks with most of our recreational drug use patterns. But the severity of these cases has also escalated. These are not transient symptoms. Many patients are presenting with neurologic deficits, psychiatric disturbances, hematologic complications, and hospital admissions are rising. They're now up to 30%, and some patients are experiencing long-term disability. Additional data that I haven't shown here is that 85% of these calls are occurring in the patient's own residence. So these are not occupational calls, they're not workplace calls. Um, and the most commonly reported effects are neurologic weakness, neuropathy, ataxia. And I suspect many of the psychiatric cases are actually initially missed because they are so difficult to diagnose. The treatment responses, which I haven't shown here, but I think is important to mention, are very varied. We were only able to find that vitamin supplementation was given in 4% of these patients. Of course, there are many reasons for that. Either it just wasn't reported at the time that either the healthcare facility or outpatient clinics had called, or they already knew to do it and didn't report it, or it just was not being cataloged in our Poison Center database. So unfortunately, we have other categories of very specific data, but for this, we don't have more granular data. We found that users also mostly combine nitrous with alcohol, cannabis, and other inhalants, but benzos are up there too. And of course, that can exacerbate toxicity and sort of cloud the clinical picture. Polysubstance use also may reflect risk-taking behaviors and highlights the need for comprehensive screening in some suspected cases. Um, Again, more than half of these resulted in moderate or major outcomes. Um, and then I will say that I think you can sort of gather that this is no longer a niche concern. Um, Rising misuse is a contributor to preventable neurologic and psychiatric morbidity. And here is our state level data from Oregon, and it mirrors that national trend, right? We really saw the spike in 2023, but we've documented both rising case counts and a higher severity of reported outcomes as well. So in 2025, actually, we ended up with about 68 cases. So more than that, almost 40 line in 2024. And so far, in January and February of 2026, we've already had at least 12 cases. So we are on track to at least meet that or outpace it by the end of this year. And a little bit of information on the legal status, right? Because how are people getting these? How is this still available? At the federal level, nitrous is legal, of course, for medical and food use, but the possession or sale for the purpose of recreational inhalation is prohibited under the FDA misbranding laws. So you're going to see on every single one of these, either boxes of whippets or these canisters, it says not for medical use, and it says food purpose only. It may say something like do not inhale. So the warnings are on they're on the canisters, but the truth is that um, these flavored canisters don't really do anything to the whipped cream. So the flavoring is likely more to appeal to the recreational user rather than the baker who wants to make a passion fruit flavored cupcake. Um, Despite this, though, the lack of consistent enforcement is really becoming quite a problem because there's widespread access to non-medical use, and that's persisting. So, food grade just means that you're allowed to eat it, but it doesn't necessarily mean it's safe otherwise. So, for example, we don't know what the effects of inhaling passion fruit flavoring are from this canister at this point. And also, some of these are being purchased from international sellers. So, there's mounting concern for oversight in terms of contaminants. There could be other acids or dangerous gases that could be present, and we don't know because anything from overseas is not regulated by our FDA. But several states have implemented laws to restrict distribution or use. So a couple of states and more oncoming have criminalized recreational possession with intent to intoxicate. That's a little hard to prove, right? In 2024, Louisiana just banned it outright. So statewide retail ban, still available online though. And then some states, such as our state, the beginning of this year, and New York previously had passed age verification laws for purchase. More robust regulations are expected to come across the country. But as of the beginning of this year, if you walk into a community shop, you were supposed to have to show them your ID to prove that you were over 18. Globally, several countries have already done this. They've responded to rising misuse, and actually, this has been well documented in some of the European literature, where very heavy party use has been described pretty well. So the United Kingdom actually uh, they reclassified it under the Misuse of Drugs Act in 2023, and that criminalized recreational possession. The Netherlands put it under Schedule 2 of their Opium Act, and then Australia implemented state level restrictions. France and Germany also adopted age-based sales limits, and several other countries are also looking into a more robust regulation process. So let's go back a little bit and just sort of try to think about how much is too much, right? Like which users do we have to be worried about? And this is hard because it's difficult to quantify excess use from person to person. So you can imagine if a person is already vitamin deplete, right? They already have a B12 deficiency for whatever reason, pernicious anemia, they are a vegan and at risk for being B12 deficient with lack of red meat and other B12 containing foods. Um, or if someone is a poor methylator, if they have a genetic mutation making it difficult for them to undergo a normal metabolic process, they may have toxicity at lower doses. So in general, though, from studies that have been published and speaking with users, we are now considering over 50 cartridges in one session. So that's about 400 grams. And remember, that was the low end of the patients who had thrombotic risk in that big study. So 50 cartridges in one session, daily or near daily use, even at low quantities, because there's a cumulative effect here. The use of large tanks, which are could be hundreds of cartridges, especially in one setting. That's all too much. But anything that results in numbness, tingling, motor coordination, those are warning signs of neurotoxicity. So that is too much, regardless of what number of whippets that is, what number of cartridges that is a sign that you are developing neurotoxicity and you have to stop. So now in terms of counseling, like who is using this? How are we going to provide essential uh, prevention to this population? So users may range from high school students to adults in their 30s, 40s. Ages higher than that are also well represented, but these are sort of the key age groups. Um, some individuals are reporting use up to 100 whippets per day. They're inhaling directly from those large tanks. So harm reduction strategies are really going to include counseling patients to avoid the large volumes, ensure adequate ventilations, and avoid rebreathing. Something I didn't mention was Most of the deaths that happen from nitrous inhalation, they're not from the side effects that we've talked about so far. Typically, it's in a hypoxic or an asphyxiation injury where patients are attaching a large mask and attaching a tube system to a big canister. So they're only breathing in the nitrous. And you can imagine someone using a balloon, if they take, they inhale one big breath off the balloon and they have that effect, the balloon lowers away from their face if it's too much, right? So they're self-titrating. You're not able to do that with a mask on. So that's where we see most of the deaths. Um, so harm reduction strategy, if patients are using, at least counsel them for sort of at some safe practices best that we can. That may also include spacing sessions, right? Try not to use it every day. Can we space you weeks apart, right? If you feel the need to use it and they're going to continue using it, let them know that this is a cumulative process and they really need to let their enzymes regenerate before using it again. Um, and then avoid combining with other substances, other CNS depressants, right? And monitoring for early symptoms. If they're going to use, be mindful if they're experiencing tingling, numbness, imbalance, cognitive changes. And you have to tell them to discontinue use immediately if these occur. So we're going to go back to our patient. She eventually admits to you that she's been using over 100 whippets weekly, mostly on the weekends. Grad school had been very stressful for her, so this is what she thought was a safe way to sort of chill out on the weekends. So she was started on intramuscular B12. She was discharged to a rehab facility. Remember, she can't walk, she needs a wheelchair. And at a 3-month follow-up, she was ambulating with a cane. But she still complains of persistent paresthesias, which is pretty common. So recovery outcomes are going to vary significantly depending on all of these factors: nitrous exposure, the extent of exposure, the volume of exposure, delays in diagnosis that allow the patient to continue using nitrous when they don't realize that this is what's causing their symptoms, nutritional status, and the degree of axonal injury by the time that they are treated. So early intervention is going to lead to better outcomes. But regardless, some patients are going to continue to experience residual symptoms. And the paresthesias and the gait instability are among the most common residual symptoms. Damage to those dorsal columns um, essentially have limited regenerative potential. So that often results in the persistent sensory deficits. And this was one follow-up study. There aren't very many. Most users are lost to follow-up. Most patients showed a functional improvement by 6 months, but some of the distal deficits were still present. So some people were still requiring assistance to walk. And again, the extent of axonal injury is what they found to be the strongest predictor of long-term disability. This is just a quick, interesting pearl on top of everything else. A group did a comparative study looking at subacute combined degeneration, which you can get just by having a deficit of B12. They compared that to a vitamin B12 deficiency versus vitamin B12 inactivation functional deficiency from nitrous. And what they found was that the nitrous-induced SCD has a more severe presentation and a poorer prognosis than the nutritional B12 deficiency alone. And this is probably reflective of those additional mechanisms, the direct myelin toxicity, all of those downstream effects by inhibiting our enzymes. And they found the psychiatric symptoms were more prevalent in nitrous cases as well. In terms of long-term care, we're going to have to do maintenance supplementation. Oral B12, folate, a multivitamin. Many patients are going to benefit from multidisciplinary rehab. So physical and occupational therapy, ongoing follow-up, maybe with those EMGs and nerve conduction studies. Mental health support and substance use counseling are often warranted. And there's this rising question of whether or not naltrexone has a potential benefit in impacting nitrous overuse. Um, we would theorize that it affects inhalant abuse in the same way that we would use it for alcohol use disorder, in the way that it impacts that endogenous opioid pathway. And actually, there was a recent study out of Vancouver, British Columbia, that followed a single patient. He was using 400 whippets per day, and they were able to decrease him to 60 whippets per week using naltrexone. So, a next interesting line of inquiry into the nitrous questions that we have. But again, this is not a niche issue. It intersects with emergency medicine, internal medicine, both inpatient and outpatient, psychiatry, neurology, rehab, social work. All of our um, ancillary providers to the central emergency medicine pathway to providing these patients with care. And I say that as an emergency medicine physician who sees a lot of patients with numbness and tingling. And I think a lot of us don't even think to ask. We ask about illicit substances, we ask about alcohol, we ask about cannabis, but we don't ask about nitrous. So, given that, diagnostic delays are very common. So, we have to have greater awareness among generalists and specialists alike to reduce the morbidity from this. And then again, several pitfalls. Let's just remember. Um, Disregarding a young patient with paresthesias, that's a big one because this is often the sentinel sign of toxicity and can be easily missed with an otherwise normal workup. If we were going to rely on the serum B12 alone, if we didn't know to order MMA and homocysteine or that MRI, and we misattributed these symptoms to maybe a functional or a psychiatric cause in young patients, right? A young patient that can't walk. This happens pretty frequently in the ED when we don't know what to ask for. Um, or missing the subtle MRI findings. Sometimes they're not as obvious as the picture I showed you, particularly in the thoracic spine. So this can all lead to missed diagnoses or delayed diagnoses. For public health outreach, I think a lot of the issues that we're having is because it's marketed with that same misleading safety as vaping was. Youth friendly packaging that's colorful, cartoonish. They're flavored, and they had that online accessibility. So like e-cigarettes, nitrous, it appeals to younger demographics, and because of this benign sort of information that younger people have been given, they think that it's safe. So there's an urgent need for targeted education and also regulatory advocacy. And I will say, I had another person tell me that in their child's high school, there were stickers of Galaxy Gas, which is one of the companies that makes those large tanks. Those stickers were popping up on students' water bottles in the local high schools. So kids know about it. Some kids are using it, some kids' friends are using it, but we should all be talking to everyone about the fact that this is not benign and this can cause real serious outcomes. So clinicians can support prevention by incorporating questions into nitrous into routine adolescent and young adult care. So pediatricians would be a great thing to ask about. Partnering with school health programs and addressing myths around the safety and reframing it as a neurotoxic substance, not just this whipped cream. That's essential to sort of getting this point across, I think. There are free confidential inhalant abuse hotlines, as well as a very robust amount of information on our Oregon Poison Center website. So please go take a look there because I know that Annie and Jen have put a lot of effort into putting fact sheets and all other kinds of information, not just about nitrous, but a lot of other things, a lot of other resources, and ways to connect with public health outreach. In fact, we have fact sheets specifically for nitrous now that our Poison Center team developed, and they're informative for the general public, patients, and provider spaces. We have them available in several languages. So I encourage you to visit. We have, again, fact sheets for many other types of exposures that are very informative. So final pearls, we're going to keep nitrous oxide in the differential for patients with unexplained weakness or psychiatric symptoms, especially in young individuals. We're going to ask specifically about its use, as it's often underreported. We're going to order our MMA, our homocysteine, and an MRI. And early treatment is going to improve outcomes, but residual deficits may persist. So treat early, refer to rehab early, recognize early. And with that, I'm going to say that the Oregon Poison Center offers 24/7 support with board certified toxicologists. We have 4 fellows, we have poison specialists, nurses and pharmacists, and educators as well. We serve as both a clinical and public health resource. We help to identify trends. There is actually a medical toxicology outpatient clinic at the Vancouver clinic that was developed by my co-fellow Matt Correa. And that's the first outpatient toxicology service in the Pacific Northwest. Um, and the last thing I'm going to say is that OPC continuously monitors regional and national data. It's uploaded anonymized into our national database system in real time. This allows for surveillance of emerging substances, cluster detection, and education outreach. So we encourage all of you to reach out with any questions, suspected cases. We are happy to take your call and help at any time. And with that, I will take questions.
Thank you so much, Courtney. We do have a question in the chat. Brooke says, hi, excellent presentation, thank you. In my area in Canada, homocysteine and MMA are considered specialty tests and results would not be available in a timely manner for rural patients. We would treat with B12 based on symptoms and history of NO. What is your experience with getting these test results and how do they change management?
That is a really great question that I didn't specifically note that we have the same problem. They're specialty tests for us too. They are not going to come back in the acute setting, especially in the ED, but we do use them to risk stratify patients based on the history and the clinical course. So if a patient admits to us that they're using nitrous, we have examined them, they have the symptoms, we would maybe get an MRI and that would help us, but we would send off those tests as well, not just because they're going to help the patient, but they help us identify in patient populations. So in these cases, go to the poison center, we can start to risk stratify our data and try to help patients in the future. So it doesn't necessarily impact the way that you're treating a patient in front of you, but it's helpful information for later. Or it's helpful to know that if a patient's homocysteine is elevated 8 times a normal limit, they may be at risk for thrombosis, right? And you might not know that until a week later, but it's maybe helpful for ongoing care outpatient too.
This question may be more for Jen. Do we receive a digital certificate of completion for attending the webinar training sessions?
Anyone who's requesting CME for this will get verification of attendance. If you're not claiming CME and you still would like a certificate, I can follow up with you. I think I see who that is and I'll reach out to them directly and see if we can sort something for them.
Thanks, Jen. And then 2 statements by William that I'll share with the group. At Bay Area Hospital in Coos Bay, we have had more than 20 cases of nitrous oxide induced functional B12 deficiency diagnosed since late 2024. Not sure poison control called in any of the cases. We're happy to take those calls, even if you absolutely know how to handle them. Having that data is helpful. It will upload to the National Poison Data center or website, and that will help us in the future as we kind of track this trend. And then also he states, in our nitrous patients, MMA elevation seemed significantly greater than patients with other causes of B12 deficiency.
Yep. And that's sort of the key there, because if you have, let's say, a folate deficiency, you may have you may have that anemia. People can have elevated homocysteine as a genetic issue, but the MMA is pretty specific for nitrous. So when we do get those 2 labs back, usually everyone has a higher elevation in MMA. And that MMA component is probably what contributes more to that direct neurotoxicity of the axon and causes a lot more of those symptoms, on top of that metabolic failure with methionine synthase down the other pathway through the homocysteine sort of methylation cycle. Um, the other thing that I will mention about that is we are probably missing so many cases from people like you who know how to treat this, because it doesn't necessarily, if you don't know how to treat this, of course, call us, but the treatment's pretty straightforward. If you look it up, it's B12 cessation of nitrous use. But if we would urge you to call us because we can track these numbers, right? Unless people call, we don't know how many people are using, and we can also find clusters, right? So if something funny is happening in your patient population in Coos Bay that's different than everybody else, we can start to look into that. We'll notice that spike in your area. So we encourage everyone to call, even if it's just a report and you don't have a question. I do that myself from our ER just to log cases to make sure that we have, a general understanding of what kind of drugs are in our community, who's using, the demographics, what other stuff they're using. So we'll ask you a bunch of questions to sort of get as complete of a history as we can. And then that will also go into the national database as well as our local database. So please feel free to call.
I think that kind of ties into our last question. Do you see any regional areas that have more exposures or hotspots?
Well, I would call Coos Bay a hotspot, and I didn't know that there were, 20 patients with significant pathology there. Um, as of right now, we have not looked specifically at, counties in Oregon that show particular hotspots, and then unfortunately, in the national data, you um, you need specialty permission to break it down by state. So we don't have that uh, as of right now. But I do know from speaking with colleagues that it seems pretty ubiquitous across the country. Um, and it seems like major city, or at least cities, there is more use. Places where they hold festivals, more use. Um, but no particular hotspots that we've been concerned about that I know of.
All right, well, we've answered all the questions in the chat, and William says thank you, and he's going to encourage ER and hospitalists to call in the future. So thank you very much, William. Well, thank you so much for attending. Thank you, Courtney, for teaching us some more about nitrous oxide abuse.
You're welcome. Please, and if anyone has any questions, please feel free to email me or get in touch with us at the Poison Center. This is our website. So please take a look around. There are many helpful things on there. And happy National Poison Prevention Week.
Thank you so much, Dr. Temple. And thanks all of you for joining. Just a reminder, please keep an eye out for a follow-up email from me that will include instructions on how to claim CME credit, including the required evaluation and CME payment. With that, we'll close out, and everybody have a great week.